Hello friends. You see, today I'll be giving a snippet overview on this topic, hypernatremia. So the context for this topic is I have covered the talk on hyponatremia, hypocalcemia, hypercalcemia. So I realized I had not done a cover on hypernatremia. I was asking my trainees to tell me the 2 to 3 broad causes of hypernatremia. So I would see that they all were fumbling. So it was quite disappointing because this is such a simple sort of, not simple, this is a condition we tend to see often, and it is imperative that we have reasonable understanding of the key sort of a overview on hypernatremia, which is so important. And it's not a very complicated topic, it's a simple topic. So it's good that I thought to go through it. And when we talk about causes of hypernatremia, essentially there would be three broad categories. So that's all it is to it. And most of my trainees were fumbling. So it is either you have an impaired thirst mechanism or you have the water loss. So there is a volume loss or hypovolemia or sodium overload. These are the three main broad categories. So it's as simple as that. And treatment also remains fairly straightforward and simple, where you have to give free water correction. So, but the whole, the nitty-gritty would be about having to understand the diagnostic pathway. I think that remains a bit of a challenge. So, friends, today is a Krishna Janmashtami, so I wish to offer my wishes to all my viewers on Krishna Janmashtami. So, I sincerely uh, pay my obeisances to Lord Krishna for being with me through this whole journey. So, and offer my prayers for him. So let's look into hypernatremia in ICU. So first we need to understand, is it important? So we call it as hypernatremia when serum sodium. So there will be MCQs at the end of it. So I'll ask my trainees here who will answer the MCQs. So if the serum sodium is more than 145 millimoles per liter, we call it as hypernatremia. And is it important? So if you look, the prevalence from the studies that I have cited is up to 47% of ICU patients would or tend to have hypernatremia. Does it have any bearing on the outcomes? Yes, hypernatremia cannot ignore. If there is a hypernatremia, it does have bearing on a lot of endpoints in ICU. And hypernatremia is shown to have a correlation in increase in ICU mortality and hospital mortality. It has a correlation with increasing the duration of mechanical ventilation. It has a bearing on the neuromuscular dysfunction and delirium components. See, many of our ICU patients are at a risk for delirium, so it does have a bearing on delirium as well. And of course, it increases the ICU and hospital length of stay. So all these typical endpoints that we see in ICU, hypernatremia has correlation with these sort of an endpoints, which we tend to follow through with regards to as an outcome indicators. And acquired hypernatremia has been shown in these studies as an independent predictor of mortality. So you cannot ignore if someone has hypernatremia. And typically, this hypernatremia you would see in someone who is really moribund. In ICU, you would tend to see in someone who has been in ICU, who is moribund, who is having certain chronic underlying diseases. We often see these patients having hypernatremia. And please bear in mind that it has a correlation with mortality. And this mortality correlation can be even up to 30 to 48% in severe cases. So the more severe the hypernatremia, higher would be the risk of mortality. And the increase in the ICU length of stay can be up to 19 days. So this was a study from Turkey, which showed that someone who has hypernatremia, the ICU length of stay and hospital length of stay can be prolonged. It can go up to 19 days. So these are some of the nuances that we need to bear in mind, that it does have bearing on all the endpoints, ICU endpoints, and it does have a bearing on mortality, and it is fairly commonly seen in ICU up to 45 to 47% as per the epidemiological data. So now the key thing I said, the question that I'd asked my trainees is, how do you broadly classify the causes of hypernatremia? So there are only three broad categories. So one is impaired thirst mechanism. So it's very, don't get too perturbed. When you read Harrison, hypernatremia, you can get quite overwhelmed. So basically, when we say thirst mechanism is impaired, where does it get impaired? When someone is an altered sensorium, obviously there is no awareness of thirst. That's all it is. That so any neurological conditions, they don't have that awareness to drink water. So these are the conditions. So that's all it is. So any neurological conditions where there is no awareness of thirst, it can be coma, it can be post-seizure, it can be stroke, any neurological condition. Or the simplistic thing for ICU is someone who's on ventilator. Can he ask for water? Can he take water and drink? He cannot drink. So someone who's on ventilator, so their thirst mechanism is assumed to be impaired because he cannot ask for water and drink. So obviously you have to give him water. And impaired consciousness, any neurological conditions where consciousness is impaired, he is not able to substitute for the water losses by drinking water. That's all it is. So where impaired, so that's where we call thirst mechanism is impaired. And in ICU patients are sedated. Obviously, you are sedated. How can he ask you for a water and replenish his volume? He may be losing volume. It may be extrarenal losses. It may be diuresis you are giving to keep them cumulative balance as net negative. You may be drying him, but he or she cannot ask you for water. It's a very simple. So when you say impaired thirst mechanism, don't think there is some major thing happening in your hypothalamus, posterior pituitary. Nothing is happening. It's just that neurologically is impaired. He or she is impaired for whatever condition. Because of that, they are unable to drink water and compensate for the water losses. That's all it is. So don't get confused thinking that hypothalamus something has happened, pituitary something has happened. All that is secondary because he or she is not able to replenish because of impaired consciousness. Someone who's on ventilator, they cannot ask for fluid. Someone who's sedated, that can lead to hypernatremia if you're not monitoring sodium. So that is one broad first. So as you see, I put it into three broad classes. So one is impaired consciousness where thirst mechanism is impaired. Second is water loss. Due to water loss, where there is a excess water loss not commensurating to the water intake for whatever reason. And this you have to divide into two categories, renal losses, extra-renal losses. So these are the only causes. So you have kidney diuresing a lot due to whatever reason and extra-renal. Extra-renal, you may be giving diuretics or someone may be profusely sweating. In ICU, we know there are a lot of other losses that happen due to insensible losses that we say due to sweating. The fact someone is on ventilator, there is a lot of extra-renal water losses, increased sweating, or someone who has temperature, very high fever, they lose a lot of water. And someone who may be having diarrhea due to whatever reasons, you may be giving laxatives for whatever reason. You would see in chronic liver disease, they may be on chronic diuresis, you will see hypernatremia happening. So that's all it is. So the broad category is impaired thirst mechanism, water loss. If you say water loss, either it is renal water loss or extra-renal water loss. And third thing is sodium overload because you have or someone who is very sick, they can have hypernatremia, or you give a sodium overload because you may have neurosurgical patients where you are giving 3% saline, 20% saline as anti-edema measures, or you may have a DKA where you may have been giving a lot of saline. So excessive sodium overload, or you may be giving sodium bicarbonate for whatever reason. So all this, so that's all it is. So when you put this question in exam and people go sort of a, they don't answer, they just get stunned. So you would really wonder, such a simple thing, you are unable to put it into these categories. So that's all is the causes. So thirst mechanism, you have a whole lot of complex mechanisms from the posterior pituitary, all those things, which we'll talk in the diagnostic tool. So it's a snippet, so I'll just give a brief overview. So just I'll take you through one case study, 65-year-old gentleman with diarrhea. So there is a lot of water loss, excessive sweating, extra-renal losses, some new onset confusion. So once they go into this vicious cycle, they won't take water. Frequent premature ventricular contractions, lab value, so 168. How should this patient be treated? So when you read about hypernatremia or hyponatremia, treatment is very simple. In hyponatremia, obviously you have to restrict water and give sodium. There's a separate video, watch it. In hypernatremia, you have to give free water. Or if you are giving sodium overload, you have to stop. But the diagnostic workup is something that can be intimidating for all our training. So you need to have some conceptual understanding how we approach this diagnosis. How do we assess diagnosis? You have to divide whether they are hypovolemic, whether they are normovolemic or hypervolemic. As I said, most causes of hypernatremia, they are hypovolemic. Okay, normovolemic is rare. Hypervolemia can happen if you are giving too much sodium overload. And the second categorization we see is whether it's acute, whether hypernatremia has happened acutely or whether it has been chronic. Most often hypernatremia tends to be chronic, more than 48 hours. And evaluation, you have to see whether there is water deficit or sodium excess. These are the broad principles of how you would approach hypernatremia. Now we'll get into normal physiology. So this is important. When even you go to Harrison's, you take any textbook and read hypernatremia, you will get overwhelmed when you look into the way how we look at understanding hypernatremia. But I'll try to simplify it. What is a normal physiology? Once our serum sodium goes up to more than 145 to 147, obviously our plasma osmolality goes up. Once it goes up, so the body is such a beautiful sort of a machine the nature and God has created. Once your plasma osmolality goes then more than 295, it sends a signal to your posterior pituitary. So posterior pituitary releases vasopressin. What is the function of vasopressin? It tends to retain water because there is less of water. It wants to retain water and keep the osmolality in the normal physiological range. So your posterior pituitary releases your vasopressin. And vasopressin, if kidneys are normal, this is where the whole problem. Vasopressin is released, kidneys have to be normal to conserve the water and your urine osmolality. So kidney conserves the water. There is water reabsorption that happens. And your urine osmolality will be more than 600 milliosmolar. So it's very simple. Keep the formula as if your vasopressin goes up, urine osmolality goes up. If your urine osmolality is low, vasopressin comes down. So please remember that very simplistically, don't get confused. So your vasopressin conserves more water. Because it's conserving more water within the body, your urine concentration increases. So your osmolality is more than 600. This is normally happening to all of us sitting here. We get dehydrated, vasopressin releases, and our osmolality tends to go up. Your vasopressin goes up, osmolality goes up. Your vasopressin comes down, your osmolality comes down. That's why you see in brain dead patient, what happens? Pituitary is not functioning. There's no vasopressin. You have free urine because your osmolality has come down. That's all it is. So don't get confused because all the trainees, they tend to get confused with this pathway. So very simplistic physiology. We've been reading this from first MBBS. So when there is hypernatremia, this is where your whole magic starts. Once there is hypernatremia, you have to differentiate whether your urine osmolality is less than 300 ml. So if it is less than 300 milliosmoles, what does that mean? Because your vasopressin secretion has been reduced. That's what it means. No, I told you. Your osmolality is low, vasopressin is low. Osmolality is high, vasopressin is high. So you have to check the approach to hypernatremia. If you have to diagnose this, that's the complicated bit. Trying to simplify. First thing you check is urine osmolality. Less than 300, you know your vasopressin is not being released. So, or there can be resistance to vasopressin. This is what we call as diabetes insipidus, central. If there is resistance, kidneys resistance to vasopressin, we call it as nephrogenic diabetes. We won't go into the details. This is the broad approach I'm giving you. And the treatment is you have to give vasopressin. This happens typically in brain dead patients where your vasopressin secretion is less, your urine osmolality also will be less than 300. So this is a straightforward. You have a brain death, this is what you see. You have to treat vasopressin and you have to monitor urine osmolality every 30 minutes to 1 hour to see if it is increasing. So then in ICU, it is not as straightforward. We come across generally in ICU, you have hypernatremia. Your urine osmolality will be between 300 to 600 milliosmoles per kg. If it comes in this range, then you have to determine what are the causes. So the causes are only two in this. Either they have osmotic diuresis or they have arginine vasopressin disorder. So how do we confirm there is osmotic diuresis? We measure total solute. How do we measure total solute? Total solute is urine osmolality into urine volume per day. So generally, it will be 600 to 900 milliosmoles per day. What are the milliosmoles? It measures sodium, potassium, ammonium, and urea. And normally, if it is osmotic diuresis, when you measure total solute, it will be more than 1000 milliosmoles per day. So if you have this sort of a situation, we call it as osmotic diuresis. Osmotic diuresis typically in ICU happens in the recovery phase of acute kidney injury. When acute kidney is improving, they go into this osmotic diuresis. You can measure total solute. It will be more than 1000 milliosmoles. So this is what the situation. AVP disorder, where arginine vasopressin is defective. That is the other cause if osmolality is 300 to 600. If urine sodium, if urine osmolality is more than 700 milliosmoles, then which means, as I said, if urine osmolality is more, vasopressin is more. So there is adequate vasopressin. So it means vasopressin is being produced to compensate. It wants to hold water to prevent dehydration that is happening. So if it is more than 600 milliosmoles, it means patient is getting dehydrated due to some water loss, either renal water loss or extra, and pituitary is producing lot of vasopressin to hold the water. That's what it means. Or you have to look at extra renal water losses. Here, this is a situation we find in ICU. ICU, either it will be osmotic diuresis. If it is 300 to 600, if it is, that is less common, it will be osmotic diuresis, which happens in the recovery phase of acute kidney. So AVP disorder, little unlikely, and it's maybe hard to diagnose because you have to do vasopressin levels. Even the general causes we see in ICU is this, where your urine osmolality is more than 700 milliosmoles, which means, well, pituitary has no problem. It is producing a lot of vasopressin. There is some water loss happening. So if there is a lot of water loss, then the question is you have to check urine sodium. Urine sodium will tell you what is happening. So if urine sodium is less than 25 milliequivalents per liter, then patient is losing a lot of water, either due to diarrhea, diuretics, or whatever. There is a lot of water losses. You have to replenish volume. If it is more than 25 milliequivalents per liter, then generally it may not suggest over dehydration, but then you have to look at fractional excretion of sodium. So here we say fractional excretion of sodium is less than 1% or more than 1%. If it is less than 1%, then kidney function is normal. If it is more than 1%, there is intrinsic problem within the kidney. That's what it means, but you can go read up about. So this is the approach. If it is more than 100 milliequivalents urine sodium, then you are giving lot of sodium, either through 3% or sodium bicarbonate, so on and so forth. So this is all is the pathway for diagnostic. So whatever you do with diagnostic pathway, treatment would be, obviously if it is central diabetes, you have to give vasopressin. For all the other things, you have to give free water. If you are giving, just keep an eye if there is more sodium going, and you have to avoid that excess sodium. So this is the algorithm, friends. So you have to remember whether your urine osmolality is more than 600 milliosmoles, or it is less than 600, 300 to 600, or more than 700. And if it is more than 700, it is due to dehydration. You have to look at urine sodium. Then you should so less than 25, more than 25, or more than 100, and then categorize what is the possible etiology. So as you see, diagnostic workup looks little bit exciting and overwhelming, but it's fairly simple if you remember these numbers. Treatment is very simple. It's always free water replenishment. So if sodium is, if they're very hypovolemic, hemodynamically unstable, you can give saline, but generally half saline or 5% dextrose and enteral free water is suggested. And free water deficit, I keep asking all my trainees to calculate. It's very simple. You have to multiply total body water multiplied by measured serum sodium minus desired serum by desired serum sodium. So I'm sure you can all look up. There are formulas for this. So, but always you have to look at free water. You have total body weight. How do we measure? It's 0.6 into body weight for males, 0.4 into body weight for females. In ICU, we take it as 0.5 into weight. So if hypernatremia is say 150 or 160, you minus 160 minus 145, that is a desired serum, divided by 140, you'll get in the liters. So rate of infusion, acute, you can correct at 1 millimoles per liter per hour. Chronic, the correction is suggested is 0.5 millimoles per liter per hour. And it should not be corrected more than either 8 to 12 milliequivalents per liter per 24 hours. One should not correct because it can lead to osmotic demyelination. Hyponatremia also can cause, hypernatremia also can cause these demyelination changes. One has to be wary that you don't correct at a high rate. So this is all it is. Treatment is simple, causes is simple, diagnosis also is simple. So if it is more than less than 600 urine osmolality, vasopressin is less, which happens in brain death patients or pituitary problems. 300 to 600, you have to look whether there is osmotic diuresis or AVP disorder. If it is more than 600, it is dehydration. And you have to look at urine sodium less than 25, more than 25, or more than 100. If it's more than 25, dehydration may be one component, but then you have to look at fractional excretion of sodium to see if the problem is in kidney or it is not in the kidney. That's all it is. Okay, now the interesting bit, MCQ. So very simple, although I thought I will intimidate my trainees with the difficult MCQs. I just put out some simple MCQs. So Dr. Diksha, what sodium levels you would cause as hypernatremia? Less than 130, 135 to 145, greater than 145, 120 to 130. Okay, she tells the right answer. So answer is C, greater than 145. Easy question, very easy question. So which of the following can lead to hypernatremia due to excess sodium? NPO status, watery diarrhea, excess administration of concentrated enteral nutrition, overactive deep tendon reflexes. Dr. Lakshmi. Sorry? Okay, I thought this was a tricky question, but she got it right. So here, see, when you give excess administration of concentrated enteral, there is a sodium overload. So that C is the right answer. So what is the first line of treatment of hypernatremia due to dehydration? Administration of sodium, diuretic therapy, hypotonic or isotonic, increased sodium intake. Dr. Benjamin. Okay, that's the right question answer. Very easy. Which of the following is a neurological symptom commonly seen in hypernatremia? Muscle excitability, excessive thirst, CNS excitability, decreased heart rate. Lakshmi. Sorry? That's what I would have thought, but apparently it is muscle excitability and twitching is the common causes. So which of the following can be a cause of hypernatremia? Corticosteroid therapy, excessive injection of water, diuretic therapy, low sodium diet. Benjamin. Sorry? Corticosteroid therapy, because it's mineralocorticoids, it retains sodium. So retention of sodium and increasing in sodium appears to be the commoner causes. So thank you, friends. So request you all to submit your valuable work to Journal of Acute Care. So of course, you can visit my website to rehear to this lecture. Thank you, one and all.